Sarah, should I go ahead and get started? Or?
Yeah, I think it's 12:10. So a couple people might be filing on, but I think it's okay to go ahead and get going.
All right. So good afternoon, everybody. I'm Adam Gray. I'm one of the hospitalists at UK and the VA. And today I'll be talking about mycobacterial infections. So we have a little under an hour to talk about mycobacterial infections. That's a lot of time. The reason this is important is, surprisingly to me, 1/3 of the world is infected with tuberculosis. So 1/3 of the people in the world. It also has the potential to be a big public health emergency if it's missed in the United States. So we have about an hour to go over it again. I'm going to try to cover all the key points from MixApp on all mycobacteria, and then try to focus on things that are most clinically relevant for the wards. So we're going to go over the clinical manifestations of TB. We're going to go over diagnostic testing of latent TB. Then we'll go over the diagnosis and treatment of active TB. And then we'll go over some of the common clinical presentations of the other mycobacterial infections you'd have to know. All right, I got a lot of random slides. So you're all free to welcome to ask questions during the transitions. I'll stop about a quarter way through each part of the lecture and for any questions or anything. I'll monitor the chat about every 15 minutes or so. So wanted to start off with definitions, just because this is an area where I often got confused. I want to stress that TB infection is simply someone who has TB. So a TB infection can be latent or active. So just want to stress that TB infection refers to people who with latent or active TB. And latent usually means, or should mean, asymptomatic. So brief on epidemiology, again, 1/3 of the world is infected. So 2 billion people in the world are infected with TB. It kills about 1 million people a year throughout the world. So it's a huge global health problem. It's not as common in the US, but it's something you will see during your residency training, about 10,000 cases a year. Big risk factors for tuberculosis are I would categorize into two things, immune dysfunction and increased exposure. So immune dysfunction, think of people with HIV or AIDS, people with on biologic agents or immunosuppressants, but it can be pretty much anyone. People with older age, malnutrition, even diabetes can be a risk factor. But the big ones that you see on test are biologic agents and HIV. And the increased exposure is just, obviously, if you're around someone or who has TB, you're more likely to get it yourself. In the US, by far the biggest risk factor is people who are born in another country. About 2/3 of all US cases are from someone who's foreign born. So if you come from an endemic country, you're much more likely to have TB than someone who's born in the US. Other risk factors in the US are homelessness, correctional facilities also. So here's just a map showing that TB is widespread throughout the US. You can see in Kentucky, it's peppered. Most counties in Kentucky have had TB, at least this reported system. So again, I just want to stress TB is throughout the US is something you should see at some point during your training, or at least it'll see you and you might not have seen it. I'm going to mainly focus on clinical things, but for the pathophysiology, I want to stress a few points. One is that actively infected patients transmit TB by aerosolized droplets. So TB is only transmitted by people with active TB. So if you have latent tuberculosis or a patient of yours has a latent TB, they should not be contagious. It's only from active infections. And 90% of people who get infected with TB are asymptomatic and latent. So the vast majority of those 2 billion people in the world who have TB have latent TB. So 90%, 9 out of 10, it's latent, no symptoms, not contagious. The risk of active TB is about 5% the first 2 years, and then about 5% for the remainder of your life. And a couple other definitions. Primary progressive TB is someone who gets infected with TB, and it becomes active right away. So it's early after you're infected. You don't really have a long latent period. You just get active TB right away. Reactivation is much more common. About 2/3 of all TB cases that are active are reactivation. So the vast majority of people with TB, it comes later in life. They were infected, then years later, they end up developing it when they were either more malnourished, more immunosuppressed, they're older, something happened with their immune system. So we're going to move on to the clinical manifestations, which is probably the most important thing to recognize. But I just want to really stress, latent infection does not transmit. So people with latent infection do not transmit TB, and they're asymptomatic. So for the clinical manifestations of TB, it depends on what type of TB you have and where it's at. But the majority of cases, 70% are pulmonary. So most people you'd see with TB, especially on a test question or on wards, would be pulmonary TB. Pulmonary TB, it's usually an indolent syndrome of usually weeks of fever and cough. So the cough is often productive. It often has bloodstreak sputum as well. Besides the weeks of fever and cough, other symptoms are chest pain, malaise, weight loss, night sweats, anorexia, fatigue, a lot of really non-specific things that I haven't found the most helpful. I think the most helpful thing is just think of it as a subacute pneumonia, or a pneumonia that presents less acute than you'd expect. Instead of days, it's weeks or months. Exams also very non-specific. Certainly you can be cachexic and malnourished. You can have crackles, rhonchi, evidence of a pleural effusion. So the key to recognizing TB on words is having a high index of suspicion. So it should be someone with weeks of pneumonia-like symptoms and someone who you have some reason to suspect it. Whether you have one of those risk factors like immune suppression, like being on a biologic agent for let's say a rheumatologic disease, or someone with HIV, or someone who's been around TB a lot. If you're from a country that has high endemic rates of TB, or you've been homeless or in a correctional facility, that's something that would at least increase your risk of your index of suspicion. So take-home points for pulmonary TB, just I would remember weeks of pulmonary symptoms, cough and fever with someone with risk factors. There are other forms of TB. Miliary TB is whenever TB gets disseminated through the lymphatics and bloodstream. So miliary TB often presents a lot more acute and fulminant. So people will present with like overt sepsis or respiratory failure. These are patients with like severe acute pneumonia who look really, really sick. I'll show you some imaging for it later on. But miliary, I would think of it as being, it's when TB gets disseminated, it's much more rare, and it's fulminant, very, very sick and life-threatening. Extrapulmonary TB is much more common in people with immune suppression. So people with HIV and AIDS are one of the more common patient population to get extrapulmonary TB, and it can be pretty much anywhere. I'm going to stress a couple of these, but it can be in the lymph nodes, the pleura, the CNS. It can be osteomyelitis, pericarditis, larynx, peritoneum, GU system. The ones I would remember, 40% of extrapulmonary TB, the most common type, is in the lymph nodes. And I'm going to show you some pictures of that in a minute. And then the other one that I've seen tested is the skeletal system. One of the more common extrapulmonary things is Pott's disease, where you get TB of your spine. As you can imagine, pulmonary TB is hard enough to diagnose in the States. Extrapulmonary is very, very difficult. How you would pick it up, I think you'd have to have, again, a high level of suspicion. So you'd have to have someone who presented with like osteomyelitis, who had risk factors for TB or some other reason to suspect it, or if they weren't getting better with your typical therapy, so they weren't responding like you'd expect an otherwise healthy patient to respond. So we talked about pulmonary TB, we talked about extrapulmonary. This is the most common manifestation of extrapulmonary. So if I was going to remember anything at all about extrapulmonary TB, I'd remember this one. It's a scrofula. It's when you get TB of the lymph nodes. The most common nodes affected are the supraclavicular nodes and then the posterior cervical chain. So you can see this patient has supraclavicular lymphadenopathy. All right. So we've covered the major clinical manifestations of tuberculosis. So we're moving along fast. We're going to move on to diagnostic testing and latent TB in a minute. Any questions so far? I'm going to monitor this again in a few minutes. So question 1, 33-year-old woman is evaluated during TB screening. She has no cough, no weight loss, no other symptoms at all. She does use heroin daily. She's transiently homeless. No other medical problems, takes no medications, vitals are normal, BMI is 20. She has needle marks on exam, but nothing else remarkable. So which of the following is the preferred method of tuberculosis screening in this patient? Would it be best to do a chest x-ray, an induced sputum exam, interferon gamma release assay, or a TB skin test? You're welcome to voice it or to put it in chat either way. Let's see. One brave person put C. That is correct. So good job, Kara. So we're going to come back to why C would be the best in a second, but let's see here. For diagnostic testing of TB, the initial test when you're trying to diagnose someone with a TB infection is either a tuberculin skin test or an interferon gamma release assay. These are the tests. They detect infection. They do not distinguish at all between latent and active TB. They just tell you whether you have TB or not. They're most commonly used for latent TB detection. The definition of latent TB is pretty much someone with a positive test on one of these two with no symptoms and no radiographic findings of active TB. And I want to really stress, if you suspect active tuberculosis, you have to do additional testing as well. And we'll get to those in a minute. But the take home would be for TB infection, trying to figure out if they have latent or active, an initial test is either a TB skin test or the interferon gamma. For the TB skin test, what they do is you inject tuberculin units in the forearm, and then you check 2 to 3 days later to see the width of induration in millimeters. So it's very, very small. And I want to stress you're looking at the induration, not the redness. So you're looking for width of induration. It's a delayed type 4 hypersensitivity, which is why it comes a couple of days later. The thing that's really important to know is that you can have a lot of false negatives. So if you're immunosuppressed, which most people with active TB, many are, if you're immunosuppressed, you can have false negatives on the TB skin test. And also, if you have an active, overwhelming case of tuberculosis, you might not respond to the TB skin test. Your body might not produce antibodies and cause this, might not cause this hypersensitivity reaction. You can also have false positives. If you've had a BCG vaccine, which is not uncommon in certain countries, then you could have a false positive on the TB skin test. I feel like they always test about the millimeter duration that makes you positive on a TB skin test. I would try to keep this very simple, and I altered this chart just to make it simpler. The numbers you have to remember on a TB skin test are 5, 10, and 15. I would just really stress the 5. People who are positive on a TB skin test for greater than 5 millimeters in duration are the highest of the high risk. So I would really stress, remember those. If you had a recent contact with an active TB patient, you're really high risk. If you have TB findings on your chest x-ray, you're high risk. And then immunosuppression and HIV are the other big ones. Then I would also remember 15 are the ones I cannot figure out why they ever got tested in the first place. They're people who have no reason to suspect they should get a TB test. And everyone else is in the middle. The majority of people fall in the 10 category, and we would as well, being healthcare workers. So for the diagnostic testing for the TB skin test, I would just really stress, remember the 5 millimeters. That's the one that would at least exclude, or that'd be the easiest thing to remember, figure out and memorize anything. And again, highest of the high risk. So contact with active TB, TB changes on x-ray, and immune suppression. The other way to diagnose TB infection, especially latent TB, is the interferon gamma release assay. I feel like this one is more commonly being used these days. It's done at UK for our employee health stuff. It's a blood test measuring the T cell interferon gamma release in response to TB antigens. And the interferon gamma release assay, or the quantiferon gold, is done in the UK, can be used for all similar indications as a TB skin test. So it can simply replace the TB skin test for any reason. It's preferred for a couple reasons too. If you have a BCG vaccine, to avoid worrying about false positives, it's preferred you do an interferon gamma release assay. And also, if you have questionable follow-up, you would also just do this test because it's a one-time blood test. You don't have to have the patient come back in 2 or 3 days. I want to really stress this too. So I see it used a lot. You don't have to do both these things. So if you do the tuberculin scan test and the interferon gamma, it's not really cost effective. So the recommendation is to do one or the other for TB screening. So our question, the two options that were most correct would have been C or D, doing an interferon gamma release assay or a TB skin test looking for latent TB. This patient had no symptoms of active TB, so you wouldn't get the X-ray or the induced sputum at this point. You'd only do an X-ray if they had a positive skin test or interferon gamma. In this patient in particular, they were a heroin user who was homeless. So I think follow-up probably would have been higher risk than the average person. So that's why that we would lean towards doing the interferon gamma release assay. All right, we have one more question before we move on to more diagnostic testing. A 30-year-old woman was evaluated for a reactive TB skin test. She developed 6 millimeters of induration after 48 hours. She had no fever, weight loss, or cough. Can't recall any exposure to TB. She has psoriasis. She takes infliximab for her psoriasis. She had a TB skin test that was negative before she started therapy for it. Vital signs are normal. She's got stable psoriasis on exam. Lungs are clear. No other abnormal findings. Just the TB skin test was 6 millimeters. So which of the following is the most appropriate next step in the management of this patient? Is it chest X-ray, the interferon gamma release assay, RIPE therapy, or no further intervention? Right. One brave soul. Rebecca was correct with A, so chest X-ray. So let's see here. So chest X-ray was the best answer here. Why? Basically, you're looking for any findings of active pulmonary TB. Even though they're not having symptoms, if they had fibrotic changes in their X-ray, that'd be very concerning. The interferon gamma release assay, this patient already had a positive TB skin test. It was greater than 5 millimeters. She was one of those highest of the high risk because of the infliximab therapy. So there'd be no benefit in doing that interferon gamma. You've already diagnosed her with latent TB at minimum. RIPE therapy would not be appropriate in someone with latent TB. No further intervention. They have latent TB. The reason we treat that is to decrease the risk of it becoming active down the road. All right, so moving along now for other diagnostic studies, we're going to go over imaging, and then we're going to go over the microbiologic studies for TB. So imaging can be confusing because there's two ways TB can classically present. One, the primary pulmonary TB, like when they get active TB right away, which is less common, it can present just like pneumonia. Classic findings for this are mid to lower zone unilateral infiltrates with significant lymphadenopathy and sometimes effusions. So it can mimic a severe pneumonia almost identically. The highly lymphadenopathy might be a little more prominent than the average pneumonia patient, but again, it can exactly mimic pneumonia on imaging. For reactivation, this is the more common form of active TB. This usually will have upper lobe cavitary disease. So we'll have these cavitary lesions on the upper lobes of the lungs or even the superior segments of the lower lobes. Upper lobe cavitation is a classic, and I'll show you some pictures of it. And it's thought to be more likely in upper lobes because of the increased oxygenation there and decreased lymphatic drainage. Here's a classic X-ray of someone with active pulmonary TB and the reactivation form. So this is the one form I would remember just because it being more common. You can see bilateral changes of infiltrates and cavitation. Both sides pretty badly. Here's another X-ray with right-sided, right upper lobe cavitary changes. So to stress, the most common presentation of active TB on imaging is upper lobe cavitation and fibrosis. For miliary tuberculosis, this is the form again that gets into the bloodstream and lymphatics and becomes like fulminant sepsis and respiratory failure. The classic finding is a miliary pattern on X-ray. It's really hard to see on the chest X-ray. We'll show it on the CAT scan as well, but on this X-ray that there's innumerable tiny dots. It's like an interstitial nodular pattern with tiny, tiny, tiny dots that are so many, it's hard to even see the individual dots. It shows up a lot better on a CAT scan, but this is a millet seed, and you can see these dots. They're so close together and so small. On a CAT scan, it will look like this little dot, 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 just thousands of dots. It's hard to even, it's innumerable. You can't even count them. So just think miliary pattern on a CT scan or a chest X-ray. A classic cause of a biliary pattern is TB, or sometimes disseminated fungal infections can do the same. So we went over the imaging. So whenever you suspect TB or someone has a positive TB test, you would get at least a chest X-ray, sometimes a CAT scan, depending on the situation. To diagnose active TB, though, besides the imaging, you have to get, if you suspect active disease, you're supposed to get a screening test with sputum with acid-fast bacilli staining. You're supposed to now get 3 sputums about 8 hours apart, and one of them has to be an early morning sample because you have a lot more TB floating around in lungs in the early morning for whatever reason. We used to have to do this every day and for 3 consecutive days, but now if you get things just right, you can rule out TB in a little over a day. For the acid-fast bacilli staining, a lot of people with TB obviously will have a productive cough, but if they can't cough up sputum and you suspect TB, you could do hypertonic saline to induce sputum. That would be the next best step if they can't cough it up themselves. If you can't get sputum with hypertonic saline and you still suspect TB for whatever reason, at that point you could consider a bronchoscopy. But bronch should be reserved if you can't produce sputum, or if you had a negative sputum test but a high clinical suspicion, or if there's other diseases that you're considering that a bronch might be helpful for. Like there's other things besides TB that a bronch would be indicated. But usually you do sputum first. It's much more safer for people doing the bronch as well to know if you had TB or not. In addition to the sputum acid-fast bacilli staining, you always get cultures. Usually the stain will be positive and the culture comes back weeks later, but the culture will confirm which type of mycobacteria, so whether it's tuberculosis or not, and it'll also give you sensitivities to the drugs. Now, I think at UK, they often do a nucleic acid amplification test as well. What this does is it can determine TB or another type of mycobacteria. So whenever you cough up the acid-fast stain, it's positive, it can differentiate which type of mycobacteria it is within a few days rather than weeks. It also can sometimes detect TB in someone who had a negative acid-fast bacilli. So it's used more and more commonly. I would remember the acid-fast staining times 3. That's like the first line thing that's common in the institution. 1 early morning sample, and then the nucleic acid amplification is an optional thing, which is, I think, routinely done at UK now. And then cultures are always done too. For extrapulmonary TB, it's much more difficult to diagnose. For pleural TB, for both of these, you'd still get acid-fast bacilli and you still get cultures. And if you grew it on a culture or you had acid-fast bacilli staining, that would lean you towards the diagnosis. For pleural TB, one mixed-up question I've seen that, because the culture results are less than half the time positive, there's a adenosine deaminase test that increases the likelihood of TB. So besides acid-fast bacilli and culture, you can get a adenosine deaminase test on pleural fluid if you have a clinical suspicion for TB. Often for pleural TB, you need to get a biopsy of the pleura as well. And the biopsy should show this granulomatous inflammation, which I'm going to go over in the next slides. For TB meningitis, I would just think of TB meningitis and mycobacteria to be very similar to fungal meningitis. So they'll give you a classic lymphocytic pleocytosis. They'll give you a high protein with inflammation and then low glucose. So TB, like fungus and bacteria, eats up the glucose and will give you a low glucose on the CSF. So you would get the typical meningitis studies you get on anybody. Then you would also get acid-fast bacilli and culture. And doing serial LPs for sampling can increase the yield. I've never seen this done clinically, but if you have, for whatever reason, a really high index of suspicion, doing multiple LPs can make it more likely you detect the mycobacteria. And we're going to go really briefly over pathology, but this is a acid-fast stain. I would just stress that basically they stain a sample. They give you acid to decolorize the sample, and whatever's left is called acid-fast staining. These are thin gram-negative rods that are classic for TB, but basically they stain the sample, decolorize it with acid, and what's left is acid-fast positive. And this is what you see on pathology. On most TB cases, we're not doing biopsies, but if someone had extrapulmonary, like a lymph node biopsy for a suspicious lymphadenopathy of unclear cause, or if they had a pleural biopsy, you'd see usually granulomatous inflammation and often caseous necrosis. This is a big area of granulomatous inflammation. And the caseous necrosis is like cheese-like on gross path. This is, I think, from an autopsy, but caseous necrosis, granulomatous inflammation, this is a lung. All right. I think the diagnostic stuff can be a little bit confusing. Any questions so far? Anything I can clarify before we go on to TB treatment? All right. So for treatment of TB, we're going to first start with treatment of latent TB. This has changed a lot. There are 5 different ways you could treat latent TB. The one I remembered as a med student and resident was isoniazid for 9 months. That was the classic regimen. You can also do isoniazid for 6 months. But these are the 3 preferred ones, according to MixApp for and some new guidelines for tuberculosis. It's basically, I would just remember the R and the I of RIPE therapy for 3 months. So you can do the rifapentine and isoniazid. This is a weekly therapy. Usually you have to do it directly observed once a week. There's rifampin and isoniazid for 3 months, or just rifampin by itself for 4 months. And these are, we treat latent TB just because that 10% risk of it becoming active later in life when you're more immunosuppressed, that you want to decrease that risk. And it's very effective to prevent people from getting TB. So just remember, latent TB, there are multiple options. First line now are the R and the I of RIPE therapy for 3 months. For active TB, I would more focus on drug side effects, which we're going to get to. But basically, you're going to have ID involved, obviously, clinically. It's 6 to 9 months in 2 phases. There's an initiation therapy, and there's a continuation phase. It's the initiation therapy for active TB is RIPE therapy. It's rifampin, isoniazid, pyrazinamide, and ethambutol, RIPE. You do that for 2 months, and then you keep the R and the I for 4 months. So the whole RIPE 2 months, R and I for 4 months, then you're done. If you have really bad cavitary disease, or if you have meningitis, sometimes the duration of treatment is longer than your typical 9 months, 6 to 9 months, and it can be up to a year. So to stress, latent TB, R and I for a few months, active TB, RIPE therapy for 6 to 9 months. So question 3, 40-year-old woman evaluated for 1 month of cough, fever, night sweats, weight loss. You suspect pulmonary TB. The community has no reported cases of drug-resistant TB. She takes no meds. Her temperature is 100.2, heart rate 95, BMI 21. She has crackles on the upper lobes. A chest x-ray shows bilateral apical fibrocavitary disease. So you appropriately will do a sputum that shows acid-fast bacilli. The initial phase of 4-drug TB therapy is started, or is planned at least, with RIPE, rifampin, isoniazid, pyrazinamide, and ethambutol. So in addition to liver function testing, which of the following baseline studies should be obtained in this patient as part of the monitoring for potential adverse drug effects of the RIPE therapy? Is it an audiogram, a CD4 count, vestibular testing, visual acuity television? So it looks like Hillary's got it correct, but I do agree with whoever said B that I would probably have an HIV test in this patient, just if they hadn't already had one. But let's see here. For the medication side effects, and this is from MixApp, the one thing that's great that makes good test questions are medication effects, just because they don't change over time very much. I mean, occasionally new things are discovered, but the majority of them are static. So rifampin, the classic thing with rifampin is it turns your body fluids orange. So your urine, your tears all turn orange. Not really harmful, but it'd be a weird thing I'd probably want to know about if I was going to take light therapy. Um, Almost all of these cause liver injury. So the R, I, and the P all cause hepatitis and liver inflammation. Rifampin, besides the body fluids orange, the other unique thing is it really can rev up and interact with a lot of other drugs. I think it's an inducer of the cytochrome P450 system, so it can make a lot of your other drugs less effective. Isoniazid, the thing I would remember for it is peripheral neuropathy. And it can cause hepatitis as well, but a big thing with isoniazid is really bad neuropathic pain. And it's recommended if someone's going to be on isoniazid, especially with risk factors, to consider pyridoxine or vitamin B6, which can decrease the risk of neuropathy. And isoniazid also can cause drug-induced lupus. So isoniazid and hydralazine are the two most common tested for drug-induced lupus. Pyrazinamide, it can cause hepatitis like the other two as well, but the more unique thing to pyrazinamide is it can increase your risk of gout. And ethambutol, the most unique thing to it is optic neuritis. So for this patient, certainly the most appropriate PROMIX was visual acuity and color vision for someone who's on ethambutol. The audiogram would be if you're considering streptomycin for long-term therapy, and vestibular testing as well for streptomycin for long-term therapy. And if someone was HIV positive, if their HIV test came back positive, then certainly we get a CD4 count. So for TB treatment, I just want to give one slide on this. There's multi-drug resistant TB and there's an extensively drug resistant TB. These are not common in the US. There's about 100 cases a year throughout the whole US. So it's not common. This is something obviously I would look up if you're dealing with it. I probably wouldn't dedicate to memory, but multi-drug resistant means you're resistant to the R and the I of RIPE therapy. So you're resistant to rifampin and isoniazid. So MDR basically resistant to the backbone of TB therapy. Extensively drug-resistant TB means you're resistant to the R and I of RIPE therapy, plus a quinolone, plus a injectable second-line agent. So you're resistant to 4 things, including the R and the I. The treatment, obviously, you're going to look this up, but it's almost 2 years of 5 to 6 agents to cure. Do not memorize this, but this is showing there are multiple therapies for TB besides just the RIPE therapy we usually stress. Some of the second line agents that we reserve and someone who we suspect could have TB that we try not to give them unless they really need it, it would be a fluoroquinolone, like levaquin or moxie. Streptomycin is one of the other more common ones that I'm more familiar with. So for prevention of TB, I think this is my last tuberculosis slide. I'm going to go over the other mycobacteria. For prevention, airborne isolation in negative pressure rooms. You're supposed to be isolated if someone has active TB until you've been treated for 2 weeks. Clinically, they're improved, and you have negative smears 8 hours apart with one early morning sample. Excuse me. BCG vaccine is a little bit controversial. It's believed to not been well shown to prevent primary infection or reactivation, at least in the US. It's not recommended routinely. According to MixApp, consider giving someone a BCG vaccine if they're going to have an upgoing or an ongoing exposure. For example, if your partner you're going to see every day has TB and you're going to be constantly exposed to it, that'd be one indication to at least consider it. The other thing to be aware of is the BCG vaccine is Mycobacterium bovis. It can cause an infection. It's a live attenuated virus. So if someone's pregnant or immunosuppressed, they should not get the BCG vaccine. All right, we are done with Mycobacterium tuberculosis. So we've conquered TB. Any questions on tuberculosis before we go over the other mycobacterial infections? All right, so we're moving on to some hard ones. 59-year-old woman, dry cough, some moderate exertional dyspnea. It's all been stable for 7 months. So 7 months of just dry cough and some mild shortness of breath. No new exposures that she knows of. She occasionally gets antibiotics for pneumonia that don't seem to help. No other systemic findings. She feels well besides his cough and breathing problems. Med history is unremarkable. She doesn't smoke. She lived her life in Georgia, takes no medications. Vitals are normal. She's got scattered bronchi on exam. A CT shows scattered nodular infiltrates, mostly in the right middle and bilateral upper lobes. So these nodular infiltrates, normal respiratory flora go on sputum culture. Smear for acid fast bacilli is negative, but the culture eventually grows MAC. So which of the following is the most appropriate next step in management? This is a really hard question. Do we do a BAL? Do we start her with clarithromycin, ethambutol, and rifampin? Do we repeat the sputum acid fast bacilli smearing culture? Do we do a video-assisted thoracoscopic lung biopsy, or do we just observe her? I see a couple B's. I see a C. So Good Sam is correct with C. I completely understand B. I think this is a little bit of a tricky question, but I'm going to come back to it in a second. You're supposed to have multiple positive cultures to confirm the diagnosis. So we're getting into now the non-tubercular mycobacterial infections. I'm going to walk through the most common ones, the ones that are more likely to see on the medicine boards. But just want to stress the non-tubercular mycobacterial infections. So all the other mycobacteria besides TB are ubiquitous and environmental. Ubiquitous, I had to look up just to make sure it means everywhere. So they're all over the place. They frequently cause infection in the lungs, the lymph nodes. They can cause skin problems and cellulitis, and they can get into the bloodstream. People who are immunocompetent can get infections from these, but the disseminated infections, when they get really severe in the bloodstream, are much more common if you're immunosuppressed. So it'd be very rare to have a disseminated mycobacterial infection unless you're immunosuppressed. The isolation of them is common. They can happen from colonization. Maybe you just have them growing in your lungs, not causing any problems. They can be environmental contamination. So from the sample, somehow it got contaminated, or it can represent active infection. So just because you grow a non-tubercular mycobacteria on a culture does not mean the patient is infected with it. You need to have radiographic findings and compatible imaging and repeat studies. This patient had radiographic findings and symptoms, but they didn't have the repeat study yet. And isolation is not required. So the non-tubercular mycobacteria, you do not have to isolate. So this one, just because you're required, it's recommended to get a repeat study, you're supposed to get the answer would be C. One of the things for this particular MAC infection, which we'll get to, sometimes the treatment is more harmful than the actual infection, meaning sometimes the side effects of having multiple antibiotics for months can be more harmful than treatment. So they really want you to repeat it to confirm. I remember seeing a couple of these cases in pulmonary clinic when I was a resident. And both times actually they were just observing and watching, which I was surprised. So the first that I want to cover, we're going to cover just a few. The first of the non-TB mycobacteria is MAC, or Mycobacterium avium complex. It can present in many different ways. I'm going to stress the main ones. The first is like the patient in that clinical vignette. The syndrome is called Lady Windermere syndrome. It's usually an older woman who never smoked, who keeps on coughing. It's like months of just productive cough. And then on imaging, they'll often have nodules and bronchiectasis, especially in the right middle lobe area. So I think in a chronic cough in an elderly woman, often they've been diagnosed with pneumonia multiple times and it's just not going away. It's just something to consider. Another presentation can mimic TB exactly. So I'll just remember MAC can, if you're a smoker, an older man with COPD or other pulmonary disease, it can look just like TB. So fibrocavitary lesions in the upper lobes, symptoms of TB. The only way you would differentiate it, you're already going to get the acid fast bacilli, and the culture would just show MAC instead of TB. It can also present as hot tub lung disease. Remember, it's ubiquitous, it's everywhere. So sometimes it can contaminate hot tub water, and it can cause a really, really severe hypersensitivity reaction where you get hypersensitivity, pneumonitis, and severe respiratory problems. So Lady Windermere, it can mimic TB, and then hot tub lung disease are the three pulmonary things. Disseminated MAC, again, all these atypical mycobacteria usually only disseminate if you're immunosuppressed, and it's most common in AIDS patients. And for AIDS, someone with disseminated MAC, usually it's like, I always think of it as a failure to thrive. They're doing poorly in every way. They'll usually have fever, night sweats, losing weight, nausea, vomiting, diarrhea, just every symptom you can think of. The only way you're going to diagnose disseminated MAC would be having an index of suspicion with someone with AIDS who's just doing really poorly, and you would get cultures, obviously. You treat it with, I would look this up, obviously, but macrolide, ethambutol, and rifampin for disseminated. All of these treatments, the macrolides are the backbone of therapy, so they'll usually get a macrolide plus a couple other antibiotics, and it's for a long period of time, usually many months. So if I was to remember anything out of that at all, it would just be MAC therapy. I think Lady Windermere syndrome is one of the more common I've seen on test. It's an older woman with a chronic cough, and then imaging will show nodular bronchiectasis. And you have to get multiple cultures positive to diagnose it. The other one I saw mixed up was Mycobacterium kansasii. The only thing I would remember about this is it can mimic TB. So it causes lung infection, just like TB, cough, fever, weight loss, cavitary lung lesions, similar risk factors to TB with immunosuppression, also alcohol abuse and COPD. You treat it a little bit similar. Obviously, you're going to look it up if you ever diagnose someone with Mycobacterium kansasii. You do not have to know that for mixed-ap. The only thing I remember is if you got someone you think has TB and they got an acid fast bacillian culture and it grew this instead of TB, it's just a different infection. You got to look up how to treat it. But Mycobacterium kansasii, I just think mimics TB. All right, our last question. 27-year-old woman is evaluated for 3 weeks of progressive swelling and pain of her right second finger. 2 months ago, she cut it cleaning an aquarium tank. Over the next several days, she developed nodular red lesion. It became red and puckered and swollen. She tried cephalexin for cellulitis and it did not work. It continued to spread inward. She now can't move her finger. On exam, it's swollen, red, tender, minimal range of motion. A nodular red lesion is noticed on the palmar surface of the right second digit, proximal to the IP joint. It's got ulceration, it's got swelling and redness. X-ray shows some soft tissue swelling of the site. And I realize this is probably a giveaway because it's a mycobacterial lecture, but let's see if anyone can get this one correct. Great job, Kara. This is Mycobacterium marinum. We're going to come back to it in a second. I was surprised. I'm putting it with this section of the rapidly growing just because it can present pretty similar clinically. But these are the rapidly growing mycobacteria. There's 3 of them, Mycobacterium abscessus, fortuum, and colinonae. Rapidly growing is a relative term. So most like mycobacteria take weeks to grow. This is about a week. So it's still much slower growing than the average bacteria infection we see. The rapidly growing mycobacteria, the one thing I would remember, they can present different ways, but cellulitis is the classic I've seen on test and clinically as well. So they often present rapidly growing mycobacteria with atypical cellulitis. So you'll have what looks to be a skin infection that is very nodular. It can often be purplish in discoloration or very, very deep in color, which I'm going to show you a picture. And they're often after some kind of trauma or surgery or kind of implanted prosthetic material, and they had some kind of contaminated water that infected it. On a couple questions I've seen related to the rapidly growing mycobacteria were both related to breast implants, and they have one of these infections at that site. Another big clue to them are they're just not getting better with normal cellulitis treatment. So if clinically you suspected someone had cellulitis and gave them multiple courses of antibiotics and they didn't get better, that would certainly raise the index of suspicion quite a bit. I think the appearance is the big thing. So the appearance, here's a picture of the fish tank granuloma, which this is actually Mycobacterium marinum, which was the question was about, but it's a very similar look. It can be ulcerating, nodular in appearance, very, very deep in color, sometimes purplish as well. This is a classic for rapidly growing mycobacteria. So just think atypical cellulitis, associated with prosthetic material. All right. And marinum is one of the classic mycobacteria with fish tanks. So if you ever have someone cut their hand on a fish tank, that's on a test, that's usually Mycobacterium marinum. So leprosy, I wanted to end just on Mycobacterium leprae or leprosy. This is also known as Hansen's disease. It's very uncommon in the US. There's just a few hundred cases a year. It is much more common in South Asia and Southeast Asia. Leprosy, it involves the skin and the peripheral nerves. So you get these really slowly progressing, disfiguring, like really nodular and scaly skin lesions associated with sensory problems and really bad neuropathy. So skin and nerves is leprosy. It's not very contagious. It's thought to be a respiratory route of transmission, but it's hard to get leprosy for someone who has it. They used to isolate people with leprosy in leper colonies because of great fear of spread, but it's really not that contagious compared to the average infection. Untreated, if someone had it and was not treated, it can have lifelong disability and neuropathy. The treatment, obviously, if you have someone you suspect has leprosy in the States, you can look up how to treat it. It's multiple antibiotics for a long time. Here's a picture of it though. It's these slowly growing nodular lesions that are really, really scaly and disfiguring. So the story would be a big clue. There's a nodular, slow growing lesion that's scaly. And the other clue is neuropathy. They'll have nerve problems with the lesions. It can cause severe pain and sensory loss. And of note, armadillos are a vector in the southern US for leprosy. So it is a zoonosis. So be careful if you have an armadillo. So to revisit our learning objectives, so we've talked for a little less than an hour on mycobacterial infections. I want to really stress the key points that you have to remember. So latent TB, the presentation is asymptomatic. They should not have any symptoms. Active pulmonary TB, the presentation is usually weeks of pneumonia-like symptoms. So fever, cough for weeks. They can have a lot of other systemic things as well, but the weeks of fever and cough in someone with risk factors is the big thing. The two risk factors are immunosuppression and increased exposure. The latent TB diagnosis options are usually a TB skin test or interferon gamma release assay. Those positive on a tuberculin skin test at 5 millimeters are the highest of the high risk. So immunosuppression, exposure to active TB, or imaging findings consistent with TB. The treatment of latent TB, there are 5 different options now. The R and the I of RIPE therapy for 3 months are a couple of the first line options. Active TB imaging, the most common I would remember is the reactivation form, which is upper lobe cavitation and fibrosis. To diagnose active TB, you would do acid-fast bacilli times 3, 8 hours apart, one early morning. That's with culture, sometimes with nucleic acid amplification. The treatment of active TB is RIPE therapy. The side effects of the meds are rifampin, orange fluids, rev up the cytochrome P50 and interact with other meds. Isoniazid is neuropathy. You give pyridoxine to prevent it. Pyrazinamide is gout, and ethambutol is optic problems like optic neuritis. And then for MAC, for the non-tubercular mycobacteria, the 4 classic presentations of MAC are it's Lady Windermere syndrome, so older woman, chronic cough with nodular bronchiectasis. It can mimic TB. It can present like hot tub lung disease from a hypersensitivity reaction. And lastly, disseminated in an AIDS patient. It's like an AIDS failure to thrive. Mycobacterium canesii, just remember it equals TB. Rapidly growing mycobacteria, think atypical cellulitis. This is Mycobacterium abscessus is the most common. It presents with nodular skin lesions that are scaly, very purplish, often from a trauma or prosthetic material that just doesn't get better with typical treatment for cellulitis. And then leprosy, the one thing to know about leprosy is just chronic disfiguring lesion with neuropathy. And the lesions are often nodular and scaly. All right, that is all for mycobacteria. Any questions or anything I can help clarify? All right, thank you all.
Thank you, Dr. Gregg.
Thanks.